Welcome to Beat Cancer, the official podcast of the UC Davis Comprehensive Cancer Center. Thanks for joining us today as we have in-depth discussions of the science, research, and advancements taking place at our National Cancer Institute designated Comprehensive Cancer Center. I'm Chris Joyce.
And I'm Stephanie Winn. We will also examine proactive approaches to cancer prevention and, most importantly, how we are breaking barriers to beat cancer in our community and beyond.
Joining us today is Dr. Orwa Aboud. Dr. Aboud is a neuro-oncologist treating patients with a variety of primary brain tumors, such as glioblastoma and low-grade gliomas.
Dr. Aboud established a multidisciplinary adult brain tumor program at UC Davis. This program focuses on developing novel clinical trials for patients with brain tumors with the aim of providing the best available treatment. Welcome, Dr. Aboud.
Thank you for having me.
Tell us what you're seeing in terms of brain cancer. Who is coming in and what kind of tumors are you seeing? And have you noticed any different sort of trend? Is it increasing? Is brain cancer increasing? Is it decreasing? Is it staying about the same?
I guess I would start by touching base on the incidence of brain tumors, which I will be concentrating on primary brain tumors, which they are tumors starting in the brain tissue. And primary brain tumors in general, they are less frequent than other type of cancers. They are the vast majority of them, which is a glioblastoma, which is about 4 to 5 patients in every 100,000 people. Unfortunately, due to their demands and devastating consequences, they are thought to be higher incidence than that. However, this is low incidence compared to other tumors. Now, when it comes to risk factors for brain tumors, which I think this is a question which we get to ask a lot, there is evidence that ionizing radiation stands as a risk factor for primary brain tumors, including meningioma and gliomas in general. Other ideas about risk factors for brain tumors in the community, which there is some studies about it with conflicting evidence, including cell phones, microwaves, power tower, etc. But when you dig deeper into the evidence, there is no strong evidence that these kind of, I would say, environmental effects to be associated with higher risk of brain tumors. On top of that, also, we get the question about the association between head trauma and brain tumors. And these are not to be related to brain tumors when you take the data deeper per se.
Well, can you tell us some of the signs and the symptoms, really, that people should be on the lookout regarding brain cancer?
That's a great question, Chris. So the most frequent clinical presentation that patients usually come to our clinic or to the medical attention are usually a variety of neurological manifestations, including seizures, headache, fatigue, and cognitive dysfunction. When we say that, sometimes people think that headache is the most presenting symptom per se. However, when you dig deeper into the data, you see that there is no phenomenon per se to suggest that a special type of headache would be related to brain tumor per se. But we would advise our patients, if in case of new onset headaches or new feature of headache in the patient, this need to be evaluated by performing neurological examination and maybe imaging in some cases to rule out the possibility of brain tumors.
And what are some of the standard treatments for brain cancer? And then what are some of the novel treatments that you're trying?
Right, that's a great question. So I'm going to take advantage of this question to just walk you through the typical, if you may say, the treatment or establishing diagnosis of brain tumor. So as we said, patient will present to the clinical setting in a different type of manifestation. He or she will be undergoing neurological examination by a specialist, and a concern for a mass might be risen. And in that case, and the first step in management of brain tumors per se is diagnosis. And for diagnosis, the first step for diagnosis is imaging. For patients with suspected brain mass, the first step in imaging, we would prefer to do an MRI, which is an imaging technique that will show us details of the brain. And we prefer to do that with and without contrast, if possible. This will show us the anatomy of the brain, along with the mass, if that's a mass concerning for a brain tumor. The next step in confirming diagnosis would be to perform the tissue diagnosis, which entail surgical intervention to take a piece of this tissue, whether it's biopsy in some cases or surgical resection. So the first step in management of brain tumors, and we are talking in this case mostly on high-grade gliomas, and that to include as well low-grade gliomas. When it comes to some type of brain tumors, including lymphoma, which is primary CNS lymphoma, the practice so far have been a biopsy, although some experts in the field, they advocate for maximum surgical resection as it's the practice for high-grade glioma. So after getting the tissue from the patient, that will be analyzed by the pathologist, and a diagnosis, pathological diagnosis would be confirmed per se. And after that, the treatment for high-grade glioma, if we are going to concentrate on that, is going to be including a combination of chemotherapy and radiation therapy under the care of a radiation oncologist, and we have a great colleagues here, and also the medical oncology or neuro-oncology under our care. Now, when it comes to the new advances in the field, when it comes to treatment for primary brain tumor in general and glioblastoma in particular, there is multiple clinical trials in the country, and some of them are here also on UC Davis, trying to answer the question to how can we be better in treatment of these tumors, including trying to use immunotherapy in treatment of glioblastoma.
We're gonna want to dive into more of about clinical trials in just a second, but I want to maybe have you expand a little bit, especially for anybody that may not know or understand. But you mentioned gliomas, and then you mentioned glioblastomas. Now, what are those? The same thing? Are they different? Could you differentiate that for us?
So that's a great question. Usually, the brain tumors in general, we call them by the presumed cell of origin when it comes to their pathology. The brain parenchyma or brain tissue in general, in normal brain tissue, is consisting of the neurons, which they are the neuronal cells, and supporting cells, which they are glial cells per se. And now, when the original cell for brain tumors is not easy to be recognized all the time. So for most of the tumors, we put them under the umbrella of gliomas per se. And gliomas, they constitute multiple type of tumors. The most common one of gliomas are high-grade gliomas, which they are by the World Health Organization or WHO. They are grade 3 and 4. And we have low-grade gliomas, which they are usually WHO grade 2. These are diffuse brain tumors. And we have also WHO grade 1, which is one type or two types of brain tumors, which they are called like pilocytic astrocytoma per se. So again, when we are referring to gliomas, it's an umbrella. and it includes multiple brain tumors. The most frequent one encountered is high-grade glioma, or called glioblastoma.
And then tragically, you see brain cancer, and it's, I think, glioblastomas primarily in pediatric patients, correct?
There is a prevalence or incidence of brain tumors, including high-grade gliomas in pediatric population, and this is being managed as well by our brilliant colleagues in pediatric neuro-oncology. However, the incidence is higher as well in the geriatric population, or more senior citizens around the age of 65 and above.
I was curious what age groups you see it in. With the pediatric patients, I mean, I think that question of what caused this, I've talked to parents who have, 6-month-olds with glioblastomas, and you wonder what would cause cancer in a baby, brain cancer.
Right. So this is a very hard question, and this is the topic of research for a lot of investigators here at UC Davis and around the country. When it comes to the question that we always encounter in our clinic is somebody will come in and they will mention that, hey, I have another family member with a high-grade glioma or a glioblastoma, or most of the time when they come to the clinic, they mention that I have a relative who had a brain tumor. Now, when it comes to this is we have to take it with a grain of salt, if you may, because sometimes, as we mentioned, the relative will end up having metastatic brain tumors, which they're usually not related. But in case if we are going to discuss the topic of familial brain tumors per se, and they are about 3 to 4% of brain tumors per se, and there is some syndromes including neurofibromatosis or von Hippel-Lindau syndromes, to mention a few. So it is by the end of the day, when it comes to our patients with family history of brain tumors, most of the time we are not able to find the causative for familial causes.
Okay. Well, Dr. Aboud, you had mentioned, you'd briefly started about clinical trials. And just for everybody that may be listening, the UC Davis Comprehensive Cancer Center, now we are an NCI-designated comprehensive cancer center, and that means that we are involved in initiating clinical trials, which also includes early stage trials. And so are there any research or any specific trials that are focusing on tumors of the brain that you want to highlight or discuss, or and it doesn't even have to be necessarily in fine detail if you don't want to, but just some of the research that you're seeing and that you and your colleagues are performing?
Great. And I think I will start by kind of get the audience to understand the concept of clinical trials, which I believe most of the people know what it is. Clinical trials in concept are a good concept in idea, but we are trying to prove it to be effective. So I always consult my patients in the sense that if we know that this treatment we are embarking on, that it's 100% effective, it would be unethical not to put everybody on that. Mm-hmm. And at the same rationale, if we know that this treatment we are trying to prove that it's not going to be effective, it would be also unethical to put anybody on it. Mm-hmm. So in summary, the clinical trial concept is an idea that we think that it could be helpful to our patients, and maybe we tried it in a small group of people and found it to be effective, and now it's the idea to put it on a broader concept before giving it to everybody per se. And for enrollment in clinical trial, it's so important to understand that there would be a rigorous criteria to enroll patients into that, because the evaluation you want the group of the patients enrolling in this clinical trial to be consistent be able to get valuable answers out of this. And the idea of clinical trials is more prevalent in areas of improvement. What I mean by that, you don't do clinical trial per se on a disease that you are already able to cure and control. Mm-hmm. And that, unfortunately, that's not the case with our primary brain tumors, where we still fail to provide cure per se to most of our patients. Although some of our patients, they have a longer survival, but most of our patients, they have a survival that we wish if it's prolonged. And that's when the clinical idea will come to play. And here at the UC Davis Comprehensive Cancer Center, we were able to bring and open some clinical trials. Some of them, they are in like national, and some of them, they are international. And it comes to play, I have about 3 examples to mention here. One of them is a clinical trial to newly diagnosed glioblastoma patients, as we mentioned before. These patients are usually treated with radiation therapy along with chemotherapy, although this doesn't provide the best treatment option for these patients, and this is why we strive to have more options for these patients. Mm-hmm. So the clinical trial which we have is called BN007. It's like kind of James Bond, kind of Mission Impossible per se, in the sense that these patients are randomized either to receiving chemotherapy along with radiation therapy, or they are randomized to receive radiation therapy along with immunotherapy. And the immunotherapy in concept have been the center of attention for a lot of clinical trials in brain tumors. And what it does, it kind of unleash or takes the brakes off our immune system to go and fight cancer. Another clinical trial, for example, we have for our patients with recurrent glioblastoma, because these patients with glioblastoma, unfortunately, they recur at some point during their disease, and at that time there is no standard of care, and that's where clinical trials come to play. A third example, we have a clinical trial for patients with oligodendroglioma, which is another type of gliomas that we did not expand on, and this is a clinical trial to establish what would be the best treatment options for these patients. And we are part of multiple centers around the country and around the globe.
What do you think is the most promising treatment on the horizon? You know, whether we have it available to us now or 10 years from now.
That's a great question, and the answer for that is we are optimistic that molecular analysis for these tumors that we have so far and would have incorporated into our World Health Organization the kind of classification for these tumors have made its way, and there is a molecular features that we are discovering with time that might lead us to having specific or targeted therapy for these tumors that might be able to provide better treatment options for these patients. Also, as I mentioned earlier, the question of the effect of immunotherapy in brain tumor. This is a question that we are excited to get answers for and see whether this will provide us with better treatment options.
Well, it sounds like there's hope, and that's a nice thing to impart to your patients, I'm sure.
Definitely. And this is a field that is very rewarding, and the future lays in front of us, and we are excited to see where our research and others will lead us.
What is the survival rate with the primary brain cancers?
Now, it depends on the tumor type per se, and unfortunately, there is always statistics. There are always numbers, but I personally, in my practice, I try to gear away from giving the patient an absolute number, because it's like, and I always give the example that if you have a newborn child and I ask you how long do you think this child is gonna live, you're gonna tell me that's easy. I'll go to Google and look up what's the median lifespan for a male or female in the United States, and you come with a number. However, this number will give me the median at the best, meaning that 50% people will live longer and 50% will live shorter. It's sometimes it's not a satisfying answer for most of our patients, because what they are trying to gauge out of this question is life planning, taking care of their circumstances, supporting their family, etc., etc. However, the answer for this question is harder than the surface, because it's not only lifespan per se, but it also quality of life, functional status, because our patients are, as obviously are affected in their brains, which will affect their cognition, that will affect their functional status and their neurological manifestations per se. So this is a hard question. Again, and I will say that it depends on the tumor type per se. Some patients, they have a longer survival with a lower grade. With a higher grade, unfortunately, their survival are shorter.
Yeah, and I'm sure that's not an easy conversation to have. But it's exciting what we're doing at UC Davis.
Is there anything else new or noteworthy that maybe we haven't covered or that you'd like to highlight?
Well, I would like to highlight here that when it comes to the care of primary brain tumors per se, it's important to receive a care in a referral center with a group who takes care of primary brain tumor day in and out, because that will reflect on the care provided, and that will reflect on the knowledge. Because I don't know how would you feel if you go to somebody and ask them, how many patients of my case, of my disease, do you see a year, and they tell you 2 or 3. That becomes a little bit discouraging for you as a patient, and so you need to be treated in a group which they usually communicate with each other, which is really important. And for example, in our institution, along with other referral centers, we have what we call the tumor board, and tumor board is a weekly or bi-weekly meeting where a group of the treating physicians include, and the scientists, but mostly clinicians, including radiation oncologists, including the neurosurgeon, including the neuropathologist, and medical oncology and neuro-oncology meet together to discuss every patient at a time, where they stand in their treatment. They discuss the imaging, and I always have to mention as well that our neuroradiologists are really key in analyzing and reviewing the images for the patient, and guiding our treatment per se. So this is very important to receive treatment in an institution who understands the disease itself, and they have the numbers. We're excited here about also our research portfolio. We collaborate here with Dr. Ornblock, who is our neurosurgeon, and he has his brilliant ideas, and he had his lab where he studies the immune responses in our brain tumors. We have a radiation oncologist, Dr. Ruben Forgoso, neuropathologist, Dr. Han Lee, and a neuroradiologist, Dr. Matt Babinski, among others. Those all together form our our group. Now, in our research, we are trying to look into the longitudinal changes in patients with brain tumors, and we look into their serum and plasma, and trying to see if there is any changes in metabolomics. What is that? That's we are so, and for these patients, what we are trying to see is collecting serum samples across their treatment and looking at their metabolomics or the metabolites which they are having in their serum, trying to detect if there is any signal for response to treatment, or whether there is any signal that will help us detect any recurrence before we see it on imaging. And on that we are working with our West Metabolomic Center under the direction of Dr. Oliver Fien at the West Metabolomic Center here at UC Davis.
It all sounds so interesting and so interconnected. I think the collaboration at UC Davis Comprehensive Cancer Center is essential, right, when it comes to saving lives, to have just the multidisciplinary team that is so committed to patients, giving them the best possible chance at a quality life. Thank you so much for joining us, Dr. Aboud.
Thank you for having me, and thank you again for all the questions. Hopefully, we were able to answer most of the questions. You guys and our patients are able to reach out to us with any questions or concern, and we're happy to be here, happy to do what we are doing.
Fabulous.
Right. Well, thanks again, Dr. Aboud, for joining us today. If you would like to get in touch with us, you can email us directly at beatcancer@ucdavis.edu. Beat Cancer is a production of the UC Davis Comprehensive Cancer Center. And for more information on our NCI-designated Comprehensive Cancer Center, please visit health.ucdavis.edu/cancer.